Everybody, it's me, Amy, the MA mentor. How you doing today? So I had just finished up a video the other day about dosage calculations. And as promised, today we're going to talk about actually administering those medications that you dosed. So let's go ahead and get right into that. All right. So as always, if you like what I'm doing, if it's helping you at all, and I hope it is, please do hit the like and subscribe buttons. It really helps me out, makes me gives me the ability to, make more videos and more content for you. So let's just go ahead and dive right in. So, medication administration. Several things we want to remember before we administer any type of medication. Um, when you are preparing to administer a drug, so the doctor is giving you the order to do so, and you are getting ready to go and retrieve that medication, there's a few things that a medical assistant really needs to know. We need to check on the patient's drug allergies. Don't always assume and rely on the fact that the doctor has already looked at these. 9 times out of 10, they have, but doctors, PAs, nurse practitioners, all your providers that you're going to work for, they're human, just like everybody else. So you really want to make sure that you've taken a good look at those drug allergies for the patient as well, just to make sure you're not giving them something that's going to hurt them. You want to make sure that you know the administration site and the technique, which we'll talk about here in a little bit. Some possible side effects that could, possibly occur even right after you administer the drug. Also, though, know the side effects that could happen later so that you can let the patient know. Make sure you understand the patient's condition. If they are, I don't know, say vomiting, you don't want to give them an oral medication. It'll do no good. They'll take it, they'll drink it or swallow it, and it'll come right back up. So just be aware of that. And then if there's any consent forms that need to be signed before you administer something, make sure you have those ready and signed prior to drawing up or retrieving your medication. All right, there's rights of medication administration. Again, if you are a current student, you've probably already heard this. If you are a MA or a seasoned MA, you may have forgotten these. It's not really something that you write down, or it's more something that you remember and go through in your head as you are preparing medications, getting ready to give medications. Um, excuse me. And after a while, it just becomes automatic, but there are some rights. There's a common 7 rights, and then there's some extra ones they've added on recently in the last few years. So the common 7 rights, and these make sense once you really think about them and put them together. Make sure you have the right patient. I mean, duh, right? Always check patient's name, patient's date of birth, have them give that to you. Even if you were the one that roomed them, I know it might seem silly, but just make sure because you bounce back and forth between a lot of patients, and sometimes it's not always easy to remember exactly who's who. Um, but check their name, check their date of birth, check that against the order, make sure you have the right person. Make sure you have the right drug. I mean, again, duh, right? If you have the right person, you want to be giving them the right medication. So make sure that you're comparing the label with the chart, with the orders before you prepare the medication for administration. Make sure you have the right dose. Compare the ordered dose with the dose that you have prepared. Make sure it's correct. You don't want to underdose a patient. You definitely don't want to overdose a patient. Overdosing can have dire consequences, but then again, underdosing can be harmful too, because if they're not getting the amount of medication they need, it's not going to help them. Make sure you have checked the route ordered or the route that is normal for that particular medication. Make sure you have the right route. Route, of course, meaning Is it oral? Is it injectable? Is it topical? Is it, what route? How is it being given? Excuse me, got a frog in my throat today. Make sure you know the right technique. Okay. Um, if it's oral medication, obviously they're going to swallow it or they're going to drink it, whether it's a pill or a liquid. If it's injectable, what's the technique? Is it going to be an intramuscular injection? Is it going to be a subcutaneous injection? All these things we're going to talk about soon, but make sure you have the right technique. Right time. Now, right time is one of the 7 common rights. And we as medical assistants, oftentimes the right time is stat. It's right now. Primarily because we're working in an office setting or a clinic setting, and if a doctor or provider orders a medication, they're ordering it to be given immediately. However, this can play a role, a very important role, if you're working in, say, a 24-hour facility or a hospital setting. So that's why that right is in there. Okay. And it's just making sure what time should that drug be given. And then right documentation. You want to make sure you document, and we will go over that today as well. But make sure you document immediately after you give it, because otherwise you could forget. But like I said, we'll talk about that in a little bit. The additional extra kind of rights, the right reason. It's good to know why the drug's being given. I mean, the patient may very well ask you why they're getting what you're giving them. And in order for a patient to gain trust in you, it's good to be able to answer that kind of just right off the top of your head. The patient has the right to know the reason. If they ask, don't give them the answer of, well, the doctor ordered it for you. Okay, tell them why they're getting it. The patient also has the right to refuse. And that goes back to why we document after we give the medication. But the patient always has the right to refuse, even if it's right up to the point where you are about to administer the medication, unfortunately. They can change their minds. All right, we talked about the routes. Here are the various drug routes. Okay. There is the buccal route or buccal, depending on where you learned how to say that word. But that is medication that is put in between the cheek and the gum, and it absorbs that way. There is inhalation therapy, nasal or oral. So nasal being like a nose spray, oral being like a nebulizer or an asthma inhaler. There's the intramuscular route. That is an injected medication directly into the muscle. There's the intravenous route. That is a medication that is given directly through an IV line that goes directly into the vein. Now, depending on where you live, what state you live in, MAs, this is kind of a tricky situation with MAs. Some states allow MAs to place IVs. I currently live in a state that does. I used to live in a state that did as well. Some do not. So you have to check with your state scope of practice for that. Most do not allow MAs to inject, or as we say, push meds through an IV. That's usually the job of an RN or even a provider. I know the state I live in currently is starting to change those, and we can do some things as long as we are being directly supervised by a provider. However, most states do not allow for MAs. So again, just know your scope of practice in the state that you practice in. There's the ophthalmic or otic route, and that could be ophthalmic being in the eyes, eye drops. Otic is, of course, or otic, depending on how you say it, is for the ears. The oral route, of course, is by mouth. The rectal route is given anytime you would give, say, a suppository. The subcutaneous route is, of course, an injection as well, and that is injected, medication is injected into the fatty tissue, or what I like to term the squishy squishy. There's the sublingual route, which is under the tongue, usually tabs of some kind that'll melt underneath the tongue. Sometimes it's a liquid that can be injected under the tongue. The topical route is usually a cream or an ointment or something like that that will then uh, be rubbed in or absorb into the skin. Transdermal is very similar to topical, only transdermal is usually a patch of some kind that contains the medication that is applied to the skin and then is absorbed through the skin that way. The urethral route, this is very uncommon. It would be more in an emergency situation, but you can administer medications through, say, a catheter if you absolutely had to. And then the vaginal route, of course, this is for medications like Monistat. Anytime, a female patient would have, say, a yeast infection or something, you can have medications that are applied vaginally. All right. So let's take a look real quick at injections because quite honestly, in the office, the majority of medications that we are going to inject, or I'm sorry, administer, are going to be through injection. Pretty much everything else is prescribed and taken at home by the patient. So there are a few different types of injections. There is the intradermal, or what we call the ID injection, subcutaneous or sub-Q, intramuscular or IM, and then intravenous, which is IV. Now, because, like I said, the majority of MAs do not do IV medication administration, we're just going to focus on the first three, which you can see here. My diagram shows you exactly where the medication goes based on that type of injection. So the ID injection, and these are done primarily for like TB testing. They still do skin tests for TB. I feel like that's going kind of by the wayside, but for now we still do it. And allergy shots oftentimes are ID. So there's a few different types of ID injections that you would do, and ID is just under the skin. Um, the picture here is a little misleading. You would actually be at a little smaller of an angle there, but it is a 10 to 15 degree angle. So you're not in the epidermis, you're in the dermis, so just under the skin. A subcutaneous injection, again, goes into the fatty tissue, which is then between the skin and the muscle. So you want to go in at about a 45 degree angle for those. You can go in at a 90 degree angle straight in with a subcutaneous, as long as you pinch the tissue up. So grab a nice big, I could do it. I have fluffy arms. So if you grabbed my arms or even my belly, you could squeeze it up and you could go straight in and still hit the subcutaneous tissue or the fatty tissue. But more times than not, it's at an angle. And then the intramuscular injections are at a 90 degree angle or straight in because those go straight into the muscle. When you're doing these, it's we don't have x-ray vision, as I like to say. Sadly, I wish we did. But you have to just kind of envision where that tip of that needle is going to end up. And then do what you need to do to get it there. And it makes a lot more sense when you think about it that way. Like I said, if you need to get in the muscle, straight in, because the muscle's the deepest part. If you have to get into the fatty tissue, well, some of us have more than others. So some it's easier to get to than others. Okay. And that's the best way to look at that. All right, let's take a look at some supplies. Here is a needle, and there are various parts of the needle. So back here, you have what's called the hub. That is the plastic portion that is going to attach to the syringe. Where the hub meets the actual needle, the metal part of the needle is called the hilt, kind of like a sword. And no, you can't go on guard when you give somebody an injection. Um, then you have the shaft of the needle, which is the long portion of the needle. Then you have the hollowed out area is what I like to call it. That is called the lumen. But then at the very tip here, right before the point, where you can actually see into the lumen, is called the bevel. The bevel is important to know because every injection you give, every type of thing you do with a needle, the bevel always needs to be pointing towards the ceiling. So always bevel up. Okay. There are various gauges of needles out there. And this goes really from like, well, not quite the largest to the smallest, but almost the largest. Um, the thing with gauges of needles is the bigger the number, the smaller in diameter the needle is. Okay, so it's kind of the opposite of what you would think. Okay, so we have here everything from a 16 gauge all the way to a 30 gauge. So most people would think, oh, 30, that's a big number. That must be a big needle. No, it's a very, very, very tiny needle, actually, around the diameter. Okay. Um, you as an MA in an office, you're not going to be using 16 gauge needles for anything. Let's hope. You may not even use 18 gauge needles for anything where you're giving an injection. Now, sometimes we'll use 18 gauge needles to draw medication up, which I'll talk about in a little bit, but um, I can only remember using 18 gauge needles like once in a while, and it's when there's super thick medication. Um, what we generally use the most of, quite honestly, is the 23 gauge needles, um, and the 25 gauge needles for injections. Um, when we're doing, say, like the IDs, so the allergy shots and the PPD or the TB testing, oftentimes we use a 27 gauge needle for that. So yeah, so 20, well, let me back up actually. 22 to 25 is probably your most common range. I like 23s a lot, but what determines the gauge that you use is the viscosity or the thickness of your medication. So if you've got medication that's like syrup, yeah, you may want to use that 18, 19, 20 gauge. Because otherwise, and I always compare it to, it'd be like trying to push a golf ball through a garden hose. It won't go, okay? Or trying to suck a really, really, really thick milkshake through like a cocktail straw. It won't work, okay? Um, so that is part of how you determine which gauge you want to use. If it's more of a very kind of watery medication, very thin, then you can go your 22, 23. Now, the reason I would use 22 or 23 for that type of thing, even maybe 25, is then decide, think about what type of injection you're giving. If you're giving it in the muscle, well, the muscle is a little firmer than, say, fatty tissue is. So you don't want to use a super, super thin needle because it may bend a little bit. You'll hear people talk about like these horror stories about breaking needles. I will tell you this, I've never broken a needle, and I've been doing this since the 90s. I've never broken a needle off in somebody. The amount of pressure that it would take to actually break one of these needles would be immense. I'm not going to say it doesn't happen, but the likelihood of it happening is very slim. So don't freak out about that. Could you bend a needle? Sure. If you use a really tiny gauge needle, you could bend it. But the likelihood of it breaking is not great. But that's why I say 22 to 25, those are not super tiny. So those are going to be less likely to break off. Um, The IDs, you're literally just going under the skin, so to bend one of those would be ridiculously hard as well. So that's what you do to determine and kind of choose what type of or what gauge of needle you're going to use. Okay. Now, one more thing about needles is now, this was not the case when I started in this business, but now they have safety or what they call engineered controls on needles. Okay. And here's just a few that I wanted to show you. They're all a little different depending on manufacturer. This is kind of probably your most common one is just the one that flips over. So this, when you're actually giving the injection, this is pushed back. And then when you go to, right before you go to dispose of the needle or right after you take it out of the patient, you literally just flip this little plastic shield over and it snaps over the needle. Now, you will see some people, and especially like in this picture, using their fingers to do these. This one you kind of have to, but those I really recommend that you safety them on a hard surface. So the edge of a table or something like that, rather than push it with your thumb, just flip it over and then push it against, like, say this is the edge of a table, just push it against that. Um, it's safer, you're less likely to slip and maybe possibly stick yourself. Because needle sticks, unfortunately, are the most common type of injuries a healthcare worker gets. So absolutely go ahead and, use that type on a firm surface. There's these that kind of slide. It's kind of hard to see it, but they kind of slide along the needle to cover it. Those you almost have to use your finger or your thumb. You just need to be very careful about it. These as well, these just slide. This part here, when you're giving the injection is down here, and then you just slide that up over the needle to cover the tip of the needle. This particular one here is a very different type. This is a retractable. Um, there's several different types of retractable needles out there. This particular one, though, I can tell by how it looks, is called a Vanish Point. And how these work is, here's your plunger. You push the plunger to expel the medication, right? Well, once it hits this part right here, it'll stop momentarily, but you will have, injected all the medication. And then if you push it one more time, the needle actually retracts. It comes into this part here. You still have to put that in a sharps container. It's got a needle in it. And you have to still be very careful about it. But those are great because like if you work in pediatrics or anything and you're giving, when you do vaccinations, you have to do like kind of one right after the other. Those are great because you can kind of lay them back on your tray real quick before you take them to the sharps container, which is not best practice. You should dispose of a needle the minute you take it out of a patient. But in the case of like babies and immunizations and things, sometimes you just can't. So those are great for that instance. All right. On to syringes. So syringes come in many, 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 many sizes. Here's kind of just a wide array of them here. I think the only one I don't have here is a 1 mil. Excuse me again. So they come 1 ml, 3, 5, 10, 20, 25, 30, 50. They even come in 60s. And here's a bunch of those here. This is a 3 right here. This is probably a 5. I can't see it. 10. Here's a 60. This is probably a 50. There's a 25. Okay. The most common that you will be using for injections is a 3 ml, a 1 or a 3, depending. And this is what a 3 looks like as well. Primarily because we just don't inject more than, say, two. I mean, the most you could possibly inject into somebody is 3 mLs at a time, but that very rarely happens. So the parts of a syringe are as follows. There are the little dose markings on the side. This whole thing is called the plunger. This part is called the barrel, and then you have the tip. Now let's talk about tips. There's two different kinds out there. Oh, goodness. Sorry about that. Just went away for a minute. There's two different kinds out there. There's this kind here that is called a slip tip. Okay. You can see that right here. And you take the needle and literally just slip it over the top here and push it down. I'm not as big of a fan of those because the tip of the whole needle can just come off if it's not pushed down hard enough. I like these better. This is called a Luer lock. And these are the kind where you actually screw the needle onto it. Those are a little more secure, much safer for sure. Okay, so Luer lock versus slip tip. And it will say on the box what type you have. So you don't have to like open the whole box up to see what it is. Okay, here is a chart that I made. You can screenshot this or whatever you want to do. This is very typical of the gauges, the lengths, things like that. Okay, now I want to talk real quick about needle length. Okay. And this whole chart as a whole. This is basics. This is guideline. This does not mean this is gospel. Okay. Every patient is different. They're all different sizes and shapes and ages and all of that. Okay. This is just a guideline to go by for the basic ages and types of injections and all of that. But what you really have to do, this is where critical thinking becomes a huge part of what we do. You have to really take a look at your patient, the type of injection that you're going to be doing, and figure out what is going to be your best way to go about it. Okay, I'll give you some examples here as we go through this. But for IDs, for all ages, we usually use either a 25 or 26 gauge, sometimes 27. Okay. 3/8 to a half an inch in needle length because we're just going under the skin. So we don't have to go that far. And the most that you can inject is 0.1 mLs. Okay, let me back up too. Oftentimes you will see, especially old school folks like myself, you'll see people write cc, which stands for cubic centimeter. A cc and an ml are the exact same unit. It's the same thing. So some people say cc, some people say ml. I said cc all my life, and then when I started teaching, I made myself start saying ml. So either way, it's the same exact thing. So don't worry about that. Okay. So again, 0.1 ml is the max amount that you're going to put just under the skin for an ID. All right, then going to sub Q here. An infant, which is birth to 1 year or 12 months, we generally will use a 23 to 27 gauge, mostly 25, 20, 27, and a 5/8 inch needle, that going into the fatty tissue, and the most that you can inject is 1 ml. For anybody older, so toddler to adult, same gauge of needle, same length, pretty much. You can go up to a 3/4 inch. And the max amount is going to be 1 ml. Where it gets very different is when you do IMs, because you have different areas you can go. different amounts you can put there. So from birth to 1 year, 20 to 23 gauge for an IM. Sometimes you can do a 25, but I recommend 23. 5/8 inch to 1 inch. And we generally do that in the thigh and no more than 1 ml. 1 to 2 years, same gauge, same length. And no more than 1 ml in the thigh or in the deltoid. As they start to approach 2 years old, or if they're just a bigger kid, you can start putting the injection into the deltoid, which we're going to go over here in a minute, for the arm. 3 years to 18, same gauge. You can get a little bit longer of a needle here, especially if you have a larger person. 1 ml in the deltoid, 2 ml in the thigh. We generally don't do injections in the thigh for adults, but we can if necessary. And the reason we would is if we need to put more medication in for some reason. Anybody that's over 18 and less than 130 pounds, you're looking at the same gauge, 20 to 23, 5/8 to 1 inch, 1 ml in the deltoid, 3 mLs in the thigh, or 3 mLs, and this is up to, of course, in the glute or the behind. Adults that are 130 to 225, you can do 18 to 23 gauge, 1 inch to 1.5 inch, max 1 ml deltoid, max 3 ml in both the thigh and the glute. And then any adults that are over 225 pounds, same gauge, longer needle, 1 to 1.25 inch, 2 mLs in the deltoid, 3 in the glute, and 5 in the thigh. Okay. Now, I was talking about length. Okay. The length of the needle is determined by the size of your patient. If you have a patient that is, say, 200 pounds, and you're going to give them an injection into the deltoid, chances are they don't have a ton of fatty tissue between their skin and their muscle. So a 1 inch needle is fine. You probably just have to put the whole 1 inch in. That's fine. Okay. If you have a patient that is smaller than that, you could still use the 1 inch needle, but just maybe go halfway in with the needle. Okay. And that's on an IM. What you're basically trying to envision in your head is how far do I have to go from their skin to get to their muscle? And if there's not a lot of fatty tissue, it's not that far. If there's more fatty tissue, it's further. So then you have to say, okay, I think a 1 inch should be fine as long as I put the whole 1 inch in there. But if you got somebody who is very large, then you may need 1.5 inches or 1.25 inches to go all the way to the muscle. Okay. That's why I say you have to just kind of look at the patient and decide. Use this as a guideline, absolutely. But take a look at your patient and decide. Okay. All right. So let's take a look at what these look like. So an ID or an intradermal injection. You can do these on the inner forearm, so right here. Okay. If for some reason you can't use their forearms or they don't have forearms for some reason, an amputee, you can do it on the back, right near the shoulder blades, or even up on the chest here. Okay. This is the one that you're going just underneath the skin. You're going to create what they call a wheal. That's that little bubble there. Okay. So about a 10 to 15 degree angle to get just underneath the skin. What you do want to do is avoid any areas that have scars, wounds, excessive hair, real veiny areas, moles, freckles, things like that, and tattoos. Now, there was long ago a big debate about whether you should inject into tattoos. And there are still people that are going to tell you not to do it. but then there's gonna be people that tell you can do it. I am the latter. There's nothing wrong with injecting into a tattoo. However, when you're doing, say, a intradermal injection for purposes of a TB test, and you know you have to get that wheal, try to avoid the tattoos if you can, because it's just really hard to see. Especially if you have somebody who has really dark tattoos, it's very difficult to see that wheal come up. So if you can avoid them, get in between them, get a lighter one, something. That's fine, but there's nothing wrong with injecting into it for sake of injection. Okay, so that is your ID. Here's your sub-Q. So sub-Q again, you can see it, right? This is what you envision in your brain. Going through the skin into the fatty tissue. This person is kind of a normal size individual looking at the amount of fatty tissue they have. So you'd go in at an angle, okay? Now you can give these types of injections on the back of the upper arm. I call it the squishy squishy. And if you want to, you can actually feel that. So like you can feel your muscle here, your deltoid muscle. If you walk your fingers back, it'll be firm, 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 and then you'll feel squish. Okay, that's where you want to do that. The tops of the thighs. So if you have to give some of the immunizations that little ones get are subcutaneous injections, you can do it there. You can give in the fatty part on the side of the buttocks, and you can do the abdomen, the lower abdomen. Okay. A lot of people really prefer the lower abdomen or the back of the arms. These two are just kind of alternate sites. On to an intermuscular injection. Now, intermuscular is straight in, 90 degrees. Again, this is what you're envisioning. Look, you got skin, you got fatty tissue, you got muscle. So whatever length needle you need to get from here to here, that's what you do. Okay. Couple different sites for this. Deltoid, of course, is probably one of the go-tos because people are not always real comfortable with dropping their pants. You can do it on the vastus lateralis, which is the big giant muscle in the thigh, which would go anywhere right in here. It's about halfway between the hip and the knee on the side of the thigh, on the side of the leg. Or you can do the glute. Now, there's two different places on the glute, and I'm sorry I don't have the diagram for you here. There's what's called dorsogluteal, and there's what's called ventrogluteal. This depends a lot on the policies in your office. I know for a fact up here where I live, a good number of the larger healthcare organizations that have, very strict policies for everything will only allow ventrogluteal injections. I'll tell you why here in a minute. My entire career did dorsogluteal because I'm just not super comfortable with doing ventral. I can do them. I just not as big of a fan of them, I guess. But the main reason why they went from dorso to ventral is because there were instances of people hitting the sciatic nerve doing dorso. Now, the way I teach it, there's no way you could hit the sciatic nerve even doing dorso, but I will show you here. So the dorsogluteal actually happens right around this area. So the way I look at it, and gosh, I wish I had that the other way. I should have put, is if you're looking at the rump, okay, the way I do it is I look at the behind, I draw an imaginary line in my mind from the top of, and I hate the word butt crack, okay, so I use the Great Divide, okay, I draw a imaginary line from the top of the Great Divide all the way over, and then another one straight down, so that basically you have created 4 quadrants of the butt cheek. Okay. If you take your thumb and put it where those lines intersect and then reach around, you can inject anywhere in that area and you are going to be well to the lateral side away from the sciatic nerve. Okay. Apparently, some people are not that good at that, and that's what has caused the shift in policy at some of these places. The ventrogluteal, let me show you here, goes more on the hip, on the side here, where you basically take your hand like this, and make a V from the iliac crest, so the hip bone, down and up, and then you inject right here. Go by what your policy is in your workplace, is all I can say as far as that goes. Okay. Other routes that we administer meds in the office. The oral route, pills, liquids. Always pour from the container into a medicine cup or into the cap of the container. Never, ever, ever pour that into your hand and be like, here. Okay, don't do that. It's not professional. It's not hygienic. Inhalation routes, again, that can be anything like this guy here, which is a nebulizer. Most important thing here is to explain to the patient what's going to happen, what they need to do, and then just monitor it. It doesn't mean you have to stay, especially with a nebulizer, it doesn't mean you have to stay in the room the whole time, because that would be counterproductive. But just keep an ear out for it, and you will hear those in an office running. And then topical routes, of course, creams, ointments, things like that. Never ever touch the tip of the tube to the patient's skin. Don't put it on your finger. Always use a tongue blade, tongue depressor, to apply any type of topical medication in the office. All right, general rules for drug administration. Only give as ordered. Triple check your medication and calculate your dose, and double check for allergies. Okay. Wash your hands, but don't leave a drug unattended, and do not handle a drug with bare hands. Okay, so when you're handling a drug, you should always have your gloves on, but don't walk away from a drug to go get gloves or wash hands or anything like that. Always ask the patient to restate their name and date of birth so you know you have the right patient. Make sure that your provider, your physician's in the office. Now, again, this is going to vary from state to state. A provider generally has to be present, and that doesn't mean they have to be right there. It doesn't even mean they have to be near you. It means they have to be on premises while you are administering medications. Different states have different policies for this. My state currently just amended all of this to where they have to be within reasonable, oh gosh, I can't remember exactly the way they said it. But you have to be able to make contact with them in a reasonable period of time. So in my state, the provider does not have to be on premises, but you have to be able to get a hold of them either by video or phone, or they have to be within a decent distance to where they can get to you quickly if something goes wrong, is basically why. So just check your state policies for that. Observe the patient for any adverse effects after you give the drug, and give instructions on any type of effects, like, is it going to make them drowsy? I always follow a very kind of strict thing when I administer meds. If I know the drug is going to make them drowsy, I don't even draw it up until I find out how they're getting home or how they're leaving the office. Because if they came by themselves and they're driving away, you don't want them getting drowsy while they're driving. So that would be an instance where you would refer to the provider for guidance on what to do. Also, you don't want to, because patients, well, people in general, oftentimes if you tell them something bad might happen to them, all of a sudden something bad happens to them, whether it actually did or not. Does that make sense? So I never would tell my patient, okay, I'm going to have you sit here for 10 to 15 minutes to make sure you don't have a reaction, because sometimes people would think they reacted. So what I always do after I give a medication, I go, okay, we're all done here. I'm going to go get your paperwork together or whatever, or I'm going to go check with the doctor and see if they need you for anything else. Go ahead and just relax and have a seat. I'll be right back. That way, by the time I go, I document, I do all of that. It's usually the 10 minutes or so, and then I can go back and be like, okay, so how you doing? Good. All right. Time to get out of here. Okay. Um, don't tell them that you're watching them for adverse reactions. Okay. And then discard any unused drugs according to the policy of your office and your state. All right, we talked about, I just mentioned documentation. This is very important. You want to chart or document immediately after you administer the medication, not before. Don't be that person who's super efficient, because I guarantee you, Murphy's Law is you will document that sucker, you'll draw it up, you'll go in there and they'll go, yeah, no, I don't want to take this. And then you have inadvertently lied. You have inadvertently committed fraud because you just documented something that never happened. And it's not like you can just go in there and erase it. Okay. Once it's in, it's in. All right. So do it after you've given the medication, but do it immediately. Don't be like, oh, I'll go one more patient. I'll do this later, because you will forget. Trust me. Chart directly from the order so that you don't make any mistakes as far as what you gave. And then be very specific. Okay. So this is just an example. I've got a kind of a template and an example here. Document in that you administered whatever the name of the medication was, the dose, the lot number, which is on the vial, the expiration date, which is also on the vial, the route or technique, the location, and then the patient's reaction. Okay. Here's an example here. I used Rocephin, which is an antibiotic that we give via injection. Administered Rocephin 1 gram. Now you can document either the weight of the medication that was given, so what was ordered, or the amount in milliliters. Either way is perfectly acceptable. You don't have to do both. Lot number, blah, 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 expiration date. I am left ventrogluteal, that's an abbreviation for that. And then patient tolerated well. Nothing happened, they tolerated it well, you're good. And that's really all you have to do. Now, if you're doing this in an EHR system, it will already be dated, it will already be time-stamped, and it will already have your initials in it. More than likely, refer to your EHR. But if you are working in a very I don't want to say old. How do I want to phrase this? If you're working somewhere where they're still doing paper charts, which is so uncommon now, but if you are, which is great. Nothing against paper charts. That's how I started out. Make sure that you date, time, and initial. Okay. But again, you probably aren't going to see that much. All right. So that is all I have for you guys today. Thank you so much. I will see you again next time. And again, as always, please don't forget, if you haven't already, to click that like and subscribe. More to come, as I'm, still just kind of getting this channel started. If you have any requests of videos you'd like to see me do, Any questions you might have, please put that in the comments and I will try to answer those as quickly as possible. But until next time, take care.